All right, we are 4 minutes past. Let's call it good and we'll move from here. So good afternoon. This is Tuesday, April 26th, virtual grand rounds. Today we have the pleasure of hearing from Dr. Carey about leadership lessons learned from COVID. We're going to get through some basic housework. So first off, all attendees are muted in this environment. So if you want to ask a question, please use the question and answer box to ask those, and I'll be moderating those and teeing them up for Dr. Carey. This presentation is being recorded and will be posted on the Caregiver Grand Rounds site, where you can also access previous Grand Rounds recordings. Continuing medical education can be attained through these portals. These will be posted in the chat after we close and start the meeting, so you'll be able to access these. You can see the notes for the specific numbers to be used. Next slide. As far as disclosure goes, essentially there's no nothing to disclose from either the planners or the speaker. Learning objectives. At the end of the session, participants will have an increased ability to describe the HAVE leadership model, discuss instances where this model was pertinent during the COVID-19 pandemic, and identify leadership tools that can help support our work as we move to a new normal. Next slide. And so do we have our reflection person on?
Actually, I am giving my own. If we can go to the next slide, please, Todd.
Okay, in that case, Dan, let me introduce you then.
Okay.
So as we introduce Dr. Carey, he has worked for over 20 years as a cardiologist in Lynchburg, Virginia, and served as Senior Vice President and Chief Medical Officer Centra, where his responsibilities included information technology services, patient quality and safety efforts, performance improvement initiatives, and functions of the medical staff at Centra's for acute care facilities. In January 2018, he was appointed Virginia's Secretary of Health and Human Resources by Governor Ralph Northam and served in Virginia and served in this role for almost 4 years. He led Virginia's pandemic response until he stepped down in November of 2021 after he accepted his role here at Providence. In December of 2021, he became our Chief Medical Officer for Providence Physician Enterprise, which is the third largest medical group in the country with over 11,000 providers spread across 7 states. He received his BA in Political and Social Thought from the University of Virginia, his MD from Harvard Medical School, and his Master of Healthcare Management from the Harvard T.H. Chan School of Public Health. With that, I'm very happy to introduce for both the reflection and our talk today, Dr. Dan Carey. Thank you.
Thank you so much, Todd, for that kind introduction. Let's go to the next slide, please. And I'm sharing this poem from one of my favorite poets, Wendell Berry, who's from Kentucky. And he's a novelist and a poet and a farmer who I think has a lot to reflect on today. And I'll just read the poem. Our real work. It may be that when we no longer know what to do, we have come to our real work. And that when we no longer know which way to go, we have come to our real journey. The mind that is not baffled is not employed, and the impeded stream is the one that sings. And the reason I included that as a reflection today is I think clinicians, physicians, and other clinicians, we are problem solvers. And if there are no problems, there are no problems to be solved. I think that's one of the joys of clinical medicine. But we also in administration and leadership, and really when it comes to leadership, that means every provider who writes an order that you're in a leadership position, we need to remember that we are often unclear about which way to go. And we need to understand that that's often the human condition, and also know that that's when we achieve some of our highest goals together. All right, next slide. So the title of today's talk, Leadership Lessons are from COVID-19, and a subtitle, Leadership, Do You Have What It Takes? I thought that the origins of a number of the grand rounds over the last 2 years at Providence have, of course, been about COVID-19. And I thought maybe looking back, it would be helpful to share some of my own experiences in leadership in the pandemic response, and maybe relate those to what I would consider part of excellent leadership and very consistent with the Providence, our caring way, and our servant leadership model and our commitment to our mission. Next slide, please. So I'll discuss three things today and hopefully leave a lot of time for questions and discussion. I'd like to cover three things before that. First, leadership versus management. I think it's really helpful to clarify that. Second, the HAVE leadership model. I won't keep you guessing about what HAVE, humility, acceptance that other people may think differently. V, vulnerability and empathy are part of an effective leadership style, especially in healthcare and especially amongst clinical leaders. And then share some of the tools of my experience as a physician leader, as a health system senior leader, and then in state government, and now back together at a very large health system in our physician enterprise. Next slide. So this is, along with the mission and vision and values, this what speaks to me and what was so attractive to have me come, and I'm so grateful to have joined the Providence team. That promise of knowing me, caring for me, easing my way. Now that's our promise to our patients and communities. But for us as clinicians, I think that's our promise to our fellow caregivers, how we will treat people, how will we in leadership positions in particular will help understand the people we serve, understand how to support our practice and our own leadership, and also how to ease their way to be successful whether as clinicians or leaders or whatever role we serve in the organization. Next slide. So for me, I think it's important to distinguish between leadership and management. They're both important. Peter Drucker, one of the true luminaries of management, taught down, I believe, at the Claremont School of Management in California, though he's from Europe originally, and wrote in the 50s and 40s and 60s, that management is about doing things right, and that leadership is about doing the right things. And I think in that very pithy comment, really distinguishes very important. Again, management is often about turning inputs to outputs, efficiently moving through a process. But when we're talking about leadership, it's also not just what we're gonna do, but what we're gonna stop doing. If something goes on the plate, something has to go off the plate. And we certainly saw that true during COVID-19. John Carter, a change management leader at the Harvard Business School, has written that we are overmanaged and underled. So I think that idea that sometimes we're so focused on the processes, which is very important to get safe and highly reliable care. It's also important to understand what are those right things, what are those key drivers that we need to accomplish that actually drive the outcomes that we want. Next slide. So the idea of inputs and outcomes are interrelated, I think, in management versus leadership. And we mentioned earlier turning inputs to outputs, but leadership is really about driving those outcomes and letting go of other processes that don't drive the outcomes, be it safer care, error-free care, no infections, no CAUTIs, no CLABSIs, you name it. What are those intended outcomes and patient-reported outcomes of how functional they are, how free of pain they are? And in reality, I've broken this apart, but effective leaders and managers are effective at both. Next slide. So I often think about leaders and executives, but I also think of physicians and other clinicians. We, in many ways, we lead clinical teams, or we support nursing functions and MAs in the office and other clinicians that are contributing to the care team. So I think this applies not only to leaders and senior executives, but also to clinicians that are leading a team, whether it be in a hospital, ambulatory care setting, an urgent care or out in the post-acute setting or making a home visit. So there are really three things. And he wrote in The Effective Executive, it's a bit dated in terms of its language, but at the same time, it really, I think, made three important points. First, that we affect or drive or encourage or develop results. Those are key things that leaders and executives and clinicians that are leading clinical teams need to do. It's about the outcomes and results that we're able to achieve. And second, you need to do that in a way that is consistent with your mission, vision, and values of the organization, and even better define just what those visions and mission are. And in our case, our promise to know me, care for me, ease my way, and not only for the patient and families and communities, but for our fellow caregivers. And then third, we need to drive those results, achieve those results together in a way that develops other leaders and supports the staff. And I think we saw that in a number of circumstances when shortages of PPE and not knowing exactly the best protocols to ventilate COVID-19 patients and respiratory failure and all the details of their care that, we were kind of making it up as we went along. Next slide. So the have leadership model, and it really comes from, it's not mentioned in either of these two books, but by Greg Hebert, who's a leadership author and executive coach that I've had the pleasure of working with my teams and working with him in first at Centra Health based in Lynchburg, Virginia, but also in Richmond in state government, and we continue our work together. And his two books, You Can't Give What You Don't Have, 2018, and Changing Altitude, How to Soar in Your New Leadership Roles, I think are excellent books to recommend. But he came up with this idea, and I think it really awaits a Harvard Business Review article that he and I have been talking about, but not yet put together. But that model of 4 critical elements that distinguish really serving leaders or servant leaders, but especially applicable to healthcare and especially applicable to the mission-based organization like Providence St. Joseph Health. And those 4 things: humility, acceptance, and I'll go into what each of these represent, vulnerability, and empathy. Next slide. So first, let's talk about humility. And Webster defines that as freedom from pride or arrogance. And when I was the chief executive of a large, not by Providence standards, but a 300-400 person medical group back in 8 or 10 years ago, when I would do new physician, new clinician orientation, I used to use the phrase, we need you to be confident enough to be humble. So not so confident that you're arrogant, that you're not open to feedback, but that we need you also to be confident enough that you can take that feedback and not have your own confidence called into question, where you lose sight of your own capabilities. So that healthy balance, and I think that's key to effective leadership. And the other element of humility is it's not about you. And I think we as clinicians understand that. It's really about the patients and families and communities we serve. And we need to take our role in the mission so seriously. But I think we just don't need to take ourselves too seriously. I think sometimes leaders and sometimes physicians and other providers get into that trap of taking ourselves too seriously. Yes, our mission, yes, the care that we provide, but we need to stay humble ourselves. And sometimes that, when there's a leader, it's got to be about loyalty to the mission, not loyalty to the boss. And I think that distinguishes some very unhealthy leadership situations. And I think the other point I want to make is don't let insecurity impede your ability to receive feedback. Healthy, dynamic teams give and receive feedback up and down any informal or formal authority scale. There's got to be open discussion, and how to achieve that, I'll suggest in subsequent slides. And it does not mean that you're self-sacrificial, that your own health, your own need for nourishment, for sleep, for all the balance of life. But it does mean that it is about the mission, and that when you start thinking about yourself and perhaps your own careerism, then you've lost that commitment to the mission again, and maybe it's an opportunity to resynchronize. And an example I'll give during the pandemic is that early in that pandemic in Virginia, a little bit later than here in Washington or on the West Coast, late in March, we had not gone down into lockdown, and there'd never been a lockdown in any state in the country. And we had a cluster of cases. An elderly couple had come back from Italy into the Williamsburg area, and there was a dinner party, and they felt a little bit feverish, but they hadn't seen some old friends, and they gathered 3 large tables in a room of a social club. And then they traveled both to Charlottesville and then down to Dallas, and there was a series of infections at each location. And in fact, 4 or 5 people at that original dinner party died. They had risk factors. They were over 65, and many with chronic conditions. And the question came up: what should we do? Should we shut down the whole state or just the Tidewater area? And I think the key element was that I think we did. The Governor Northam is a pediatric neurologist, and I think he had a clinician sense of humility. Yes, you need to be positive. Yes, you need to have a positive outlook. But command and control doesn't work that well when you really don't know the answers, and you need to bring forth the best suggestions from our Department of Health, from our local emergency managers. And I think we started off on the right foot by asking for broad input. And then the goal was not to make everybody happy. The goal was to have the most effective plan to both keep our citizens safe, but also to not unduly shut down the economy, because the most vulnerable, because of income insecurity, food insecurity, transportation insecurity, and the like, are most vulnerable indeed, and could have even worse or comparable negative effects. Next slide. Now, acceptance is not that you agree with someone. It means that you accept that other people think differently, especially if you're the leader. And when you demonstrate that as a leadership behavior, thank you for sharing what you disagree with or what you have questions about. Let me hear more about that. Explain why you think that way. And the leader needs to be open to persuasion and new viewpoints, and must remain curious. Now, always, I knew that in the cardiac cath lab or in a code, there had to be someone giving orders, and that you had to be clear and very directive. But that's not most situations, and even stressful situations. You want to make sure you get the best opinions of the entire group, and especially during the pandemic, whether it was in an ICU or in management. Getting those best ideas were the hallmark of the most effective healthcare organizations. And I think it's key that the team tells you what you need to hear as a leader or as a clinician at the bedside, not what you may want to hear. That I, as doing carotid stents, didn't want to hear that Mrs. Jones, who just had come in with a stroke, she was symptomatic and was a poor candidate for endarterectomy, and she was referred for stenting. But guess what? Her neurologic signs and symptoms worsened, and she may have had a paraprocedural stroke. I need to hear that, and other leaders in other situations need to hear things they don't want necessarily to hear. And the example I give during the pandemic, and this, by the way, is the most overtly political thing I will say, just because I was there and the governors were all there from video feed and their immediate leadership staffs, with the president. And this story comes from early April of 2020, when we were waiting for federal commitment to provide national resources on PPE and testing, and on frankly starting a vaccination effort. And that was when the governor had ostensibly, the president had ostensibly brought all the governors, that we were all in our individual situation rooms, and he was in the cabinet room with Secretary Azar and some other officials. And that's when he announced, the then president, we're going to be your backup. Governors, go at it. We know your populations are different. We know your situations are different. It's up to you to manage this, and we're your backup, which frankly was quite shocking to most governors, whether you're a Republican or a Democrat. And we were very close. We were a Democratic administration, Larry Hogan, a Republican in Maryland. We worked hand in glove on policies and sharing of resources and best practices throughout the pandemic. And Jay Inslee, the governor of Washington, where I am now here in Seattle, raised his hand and said, Mr. President, we don't need a backup. We need you to be Tom Brady and march us down the field and score the touchdown, and we'll be behind you 100%. We need federal leadership. And that shut down the conversation. That was not an answer that the then administration wanted to hear. And I remember that because that was not, although it was billed as a discussion, it was really not an open discussion. That leadership really did not want to hear dissenting views or alternative views. And that shut down the whole conversation. And I realize that's an oversimplification of a very complex situation. And I share that just because I experienced it. And it's a reminder to me that highly effective leadership accepts that other people view differently and at least hear them out, show the respect of differing views. And it doesn't mean you're agree. It doesn't mean you're going to change the plan, but it means you're welcoming and most certainly don't question the commitment or loyalty of folks who bring up alternative or dissenting views. And I think one thing that Charles Duhigg, who's a writer, or had been a writer for the New York Times, wrote his book, and I forget if it's Smarter, Better, Faster, or some order of that, which is a good book. I would recommend it, about teams, that they studied Google, and the most effective and creative teams were also the most diverse. So you had diversity from, often it was skill set, often it was age difference, often if it was race, ethnicity, gender differences. And the one thing, though, is that everybody had to speak up, that was enforced. When that was enforced as a group norm, they were higher performing teams. And I've seen that again and again, and I bet you have too, especially at morning huddles, especially when there's a critically ill patient and the care team is gathered to try to best step is. Next slide. Vulnerability. Now, the dictionary indicates that vulnerability is a willingness to show emotion or to allow one's weakness to be seen or known. And this is a tough part, willingness to risk being hurt. And that may be counterintuitive when it comes to effective, decisive leadership. But in fact, I'm sure you've seen this in the clinical world, as I have, that effective leaders know how to ask for help. And when leaders ask for help, it empowers others on the team. It eliminates this false pride and really focuses on the problem rather than the status of individual team members. And leaders that model that way, asking for help and realizing that asking for help and admitting mistakes is a strength, not a weakness. And my example of this is actually a pretty hard won lesson that I had. And it's not remarkable because woe is me, but it was a why not me story. I, like many clinicians, I was not a clinician during the pandemic, but I was briefing the governor every morning at 7 on weekdays and 8 o'clock on weekends, gathering the team's information from the Department of Health and the Commissioner of Health and Behavioral Health and all the other inputs, and making sure that we had a tight briefing, and then press conferences. And I know that that's not caring for patients. It's not losing patients. but it was stressful for me. And I used to pride myself on, being a weekend on call where I was both the first call cardiologist on Saturday and the intervention call Friday through Monday, and somehow I survived it. It probably wasn't the best patient safety situation and wouldn't be tolerated today, but 30 years ago it was. And I raise that because after 8 or 10 or 12 weeks of this grind in the spring of 2020, I really had reached I knew I was getting tired. I knew my sleep was starting to be disturbed, but I kind of lost my sense of how to get out of it. And because many of us were still going into the office, but not everyone. I think any peers that might have said, Dan, you're having trouble there, weren't as available perhaps to give me that feedback. And I went to the governor and to the chief of staff after about 3 months of the pandemic and said, listen, I'm not sure I can do this anymore. I'm not as effective as I need to be, sir. I'm not giving you my A game. And I think I'm not sure I can keep doing this. And I need help. And I was so fortunate that both the governor, as a caring individual, a pediatric neurologist, as I said, as well as an excellent leader, and the chief of staff said, Dan, we've been leaning on you for the last 12 weeks. You're positive energy. Let us take it for a little while. And did not criticize me for expressing that I needed 2 or 3, 4 days off to kind of get my bearings back. And that's in fact exactly what happened. But here was the surprising thing. After I raised my hand, and I'm breaking down here, we changed the governor's schedule. We changed everybody's tempo. We were trying to run this marathon like it was a hurricane, which is what most emergency responses are based on, weather events or earthquake events, not prolonged pandemics. And we changed the governor's schedule, or it changed after my comment. And I realized that I raised my hand and said, I can't tolerate this. But guess what? Other people couldn't either. And we needed to rebuild our schedule and how we allocated our time so that we were ready for the marathon that we were already in, and that was going to continue, obviously, for really another 2 years and ongoing. So that vulnerability I've seen again and again when I've raised my hand and said, I'm not sure what to do next to the teams I support, to my peers, even to my boss, because we don't always know what to do. When we ask for help, it often is the most powerful leadership behavior that we can demonstrate, and also admitting mistakes and owning up to mistakes, because guess what? We're all human. Clinicians, doctors, nurse practitioners, PAs, etc. We're human too, and all caregivers are human, and we do make mistakes. Now, in a high reliability culture, we want to make sure that those are limited and the patients are shielded, but we're human, and we need to have each other's back and make sure that we admit to those mistakes, and also know that our whole frame of reference won't be brought down because of that. Next slide. The last, empathy. And this is an essential part of our caring way. And as that's rolling out, it'll be important for all of us to understand a little bit better about empathy. And I know I'm on a journey of learning about it and how to demonstrate it better. Webster says the ability to understand and share the feelings of others. So it's being with people in their emotion. And it really is about meeting people where they are. And a quick story. We didn't want to travel, or my team didn't want to travel because that would gather people together. But we realized that it was so important to get out into the field with proper precautions and follow the gathering rule, the mask rule, and the distancing rule that were very important. But often we didn't have a truckload of PPE to deliver to a health department or to a medical center. We did do everything we can to supply that and went into the international market and lots of things, but we often didn't have a lot. We didn't have testing supplies early on, and we certainly didn't have vaccines. And meeting people where they were, hearing their stories, acknowledging that. And I'm sure here at Providence in the clinical settings, having peers as well as leadership be with you, present, understand what the challenges are, bring whatever resources that could be brought to bear. But often it was empathizing with just how difficult it is. And when I would go to that local health department and just hear the stresses and strains of what they're trying to confront, trying to organize in their communities, or any other health-related, or frankly, childcare, behavioral health care, social service organizations experiencing similar difficulties caring for the needs of the populations that they serve. That was often enough, though, again, that having that just presence, being with them in that emotion. And that is such an important leadership behavior, and also to share with families and with patients, but also with our, it works north, south, east, and west, meaning having empathy for the customers, the patients, the clients, families that we serve. Empathy and for the frontline workers that we support, but also for our peers, that they're confronting challenges that maybe for whatever their own characteristics are more challenging, that they're experiencing that differently than you might. And also for our supervisors, for those that support us, that they often have incredible challenges, and we are not always going to be aware of just what those challenges are. And I think that really helps us start with that positive intent, an assumption of positive intent. Next slide. So the have leadership model is what's to what end? It's really to create a safe environment that builds trust and psychological safety to allow the best work to be done. And remember, this is not about being a nice leader. It is about kindness, but it's not about niceness per se. It's about what effective leadership looks like. And a leader who demonstrates these qualities consistently in word and in deed will get the most out of their team, help their team develop, help meet the goals of the organization, care of an individual patient, care of a clinic's population, or care of the entire population that we're trying to care for in various arrangements. And it's, again, not part of squishy, indecisive leadership, but in fact, a part of decisive and effective leadership. Next slide. So I put this together, which is a mashup of other people's ideas, but that foundation of psychological safety that's so important to a high reliability culture that also is committed to compassionate care and also compassionate treatment of our caregivers, our peers, and our leadership. And you need that to build trust. Trust builds engagement, commitment, and accountability, and eventually achievement. So that foundation of psychological safety is one of the most important byproducts of that have leadership. Next slide. So a couple of other things I want to share before we finish up and open it up for questions is some tools that I started to use. And again, this was not proprietary, these 6 questions. And this is kind of blocking and tackling for human resources, but sometimes forgotten in healthcare. Do I know what is expected of me at work? Do I have the right materials and equipment I need to do my work right? At work, do I have the opportunity to do what I do best every day? And these last 3, in the last 7 days, have I received recognition or praise for doing good work? Does my supervisor or someone at work seem to care about me as a person? And is there someone at work who encourages my development? So as we think about that, think about our own situations, and also think about the people that we interact with, the folks who look to us for direction. It's often informal, but many of the staff in a clinic or in the hospital look to the clinicians for leadership and asking about their own development. Many of our caregivers are in continuing educational programs, some rising in their clinical qualifications and encouraging them along the way, thanking them for the great care they provide. You know, we're all human, and this really works. And sometimes I think in healthcare, we forget that we're human and need to treat our coworkers and those that we support with dignity and respect. Next slide. And I think I'll skip this one in the service of time. Next slide. And as we come to a close, this came from a talk that John Toussaint, I think this version of my slides had the reference taken off, but a talk he gave. John Toussaint is a primary care physician who also was the CEO of Theta Care, one of the outstanding health systems implementing, lean management, high reliability, the Toyota management system. And my health system went there for a 2-day visit, and I had a chance to talk with him and our whole leadership team. 15 people went. And this was one of the slides he subsequently had at a talk he gave to the American College of Healthcare Executive, ACHE. And it, I think, contrasts so clearly white coat leadership characteristics, and I'll explain what that is, and improvement leader characteristics. And white coat could be a physician from the 1950s, or it could be really anyone. And frankly, I've experienced folks on the left side in every role in healthcare, and then improvement on the right side. So that exhibiting an all-knowing attitude versus demonstrating humility, adopts an in-charge posture versus exhibits curiosity, demonstrates autocratic tendencies versus facilitates improvement efforts, adopts the buck stop here approach versus teaching others, and goes last through showing impatience versus learns from others, blames others, communicates effectively, controls others versus perseveres. And for me, this outlines so clearly where we want to be with a have leadership model, a servant leadership model, and embodying what we're all going to be learning together in our caring way on the right side. So for me, it just is a great crystallization of those principles. Next slide. So I've already read this poem, but I think why I show this one more time is that this work that we do is incredibly hard. It's never been harder than the last 2 years. And I also think that it's been an opportunity for so many in healthcare delivery, but also in public health and in government to show really how much we care and how much we can innovate despite impossible needs and impossible odds against us. And again, when you don't, that middle line, and that when we no longer know which way to go, we have come to our real journey. And I just love the embracing the problem and problem solving. And it's always the next problem, and it's a process, not a destination. Next slide. So thank you very much for your willingness to listen. Thank you so much for all of you here at Providence, that over my last 4 months, my first 4 months here, you've taught me so much. I'm so proud to be a caregiver here at Providence, and I congratulate just what Providence has done in all of its missions and all of its locations to serve the patients across this country. So thank you very much, and open to answering questions. Todd, I'll hand it back to you.
Thank you. That was a phenomenal overview of leadership. And I've got a few questions, actually. I'm kind of curious. You took us through the HAVE model, 4 components: humility, acceptance, vulnerability, and empathy. I'm wondering, in your long experience in medical leadership, what's the one most people have the biggest trouble with?
Great question, Todd. I think the biggest difficulty is in vulnerability. I think letting your guard down and admitting that you're human, you've made a mistake. It's not necessarily the most important one, but I think getting to that, it's one thing to say you're humble and don't know an answer. It's another thing to accept another point of view as not being your own and maybe needs to be considered. I think we have experience as caregivers with the empathy and being very overt about that. It's not easy, but I think it's more accessible. I think that willingness to be hurt and willingness to show what could be interpreted by some as weakness, I think that's the one that I'll simply say for my tribe of physicians, that's the number one challenge I see, but not just for physicians, obviously for professionals of all types. And I think that's probably true whether you're a fighter pilot, an architect, or a high-performing knowledge expert like our nurses are, like our other clinicians are. So I think that vulnerability is the one, because they got to trust the people around them, because we've all been hurt. We've all been hurt. And I think that's the one that we've got to be willing to talk about that in the work site, I think. And that's something that we'll, I think, talk more about in our caring way.
Great answer. Thank you. Can you give an example of when a person reports to you was not displaying these good leadership behaviors, and how did you address it then, and what was the outcome? How do you coach to this?
Yeah, that's a great question. Well, first, it's good to have the concepts that are, and I think I don't want to misalign our caring way, because I think they're built on that same foundation of empathy and compassion and sacred encounters. And I think this is very supportive of that. But I think, I think back to, I was the head of a cardiovascular center and then head of the, so there, and then I was chief medical officer of the health system. So I had lots of these kinds of conversations. And I think it's not the first thing you mentioned, by the way. I did use it when this humility that if somebody was just so defensive, you couldn't mention anything. I often resorted, whoever it was, I need you to be humble enough to, confident enough here to be humble. I know you're a good surgeon. I know you have excellent training. I know you generally drive wonderful outcomes, but we're talking about this one case. Can you be open with me about this? I mean, phrases like that sometimes were helpful, but if it's a crucial conversation, then you're really managing that. This is really in development of the culture, and maybe after someone's cooled down, if there's a behavior, again, humans are humans, and guess what? Doctors and nurses and other clinicians are humans too. So there's misbehavior, there's use of credit cards, et cetera. So all of those things, in the heat of the moment, it's good to have this baked in to the culture. But I think we've got the right bones here at Providence.
Great. There's a question if you'd be willing to share your slide deck. I think the answer is pretty much yeah, just email you.
Yeah, email me. Daniel.carey@providence.org. There it is.
I'm not seeing any other questions pop up. So we're approaching the top of the hour. Yeah. Oh, wait, here we go. What advice would you give someone reporting to a leader who could use growth in this area? So my boss, for example, I'm not saying my boss, but if someone's boss needs help, how do they gently suggest?
Yeah. It takes a lot of tact, but I think we have to be people of courage for this organization and any organization, especially healthcare. It's got to be psychologically safe to bring something up. And I'll give a couple examples. I was in a situation where the CEO, I was the chief medical officer, and the CEO had developed, he was local and maybe not a lot of experience in the greater world, and personal loyalty. He didn't think this so, but personal loyalty became part of it. It wasn't loyalty to the mission. And I had to try to make it say, boss, I'd like to bring something up, and it's a little uncomfortable for me because I respect you. You're my boss. You're the leader of the organization, and yet I think it's important for you to hear something. Can I talk about that? So it's really the elements of crucial conversation, which I still read my notes from the courses and look at the diagrams, because crucial conversations is perhaps the most important skill that I'm not saying leader, as a human being and working in a family or in any situation with other human beings. It's so powerful, and I'm getting better at that as we go, but make it safe. And I gave him feedback that whether he intended or not, inadvertently, that there was a sense that there was a personal loyalty to him. So, boss, if it's about personal loyalty, they're going to tell you what you want to hear, not what you need to hear. Because if it's loyalty to you, and this was in 2012, and I think we saw that playing out on the national stage subsequent to that. I think the key is to be honest and direct, and frankly, asking for permission is kind of a great way to start it, because then they know you respect them, you want them to be better, and you're also staying humble, because maybe this doesn't, maybe I don't know all the story. So that's how I've done it, but I bet there's 100 stories as to how it can be done well. But you've got to have courage, because even though people do react, and you've got to have courage, and that's okay. And that really is okay.
Yeah, leadership is a tough thing. Courage with humility, both.
So Todd, thanks a lot for this opportunity. This is something near and dear to my heart. I'm happy to have other conversations with folks. So thank you.
Thank you. And I think I speak for the audience to thank you as well for attending. So I think with that, we'll give you guys back 8 minutes and get on to our next meeting.
Thanks so much, Todd. Thank you all.